Have you ever wondered if you've had a migraine? Chances are, if the following symptoms ring a bell, you might have had one. Have you had a headache that lasted a long time? When it happened, did your face hurt on only one side? And did you feel nauseous or throw up? Were even the quietest sounds and faintest lights painful? According to the International Classification of Headache Disorders, or the ICHD-3, there are three types of migraines. The first are migraines with aura, which are characterized by the experience of some kind of sensory, motor, or verbal disturbances, often in the form of flashing lights, tingling sensations, or a loss of speech. Then there are the migraines without an aura, and finally, chronic migraines, which are migraines with or without aura that occur more than 15 times a month for over 3 months. Except for those specific criteria, migraines can have a variety of additional symptoms occurring at different stages. The four known stages of migraine are prodrome, the aura, the headache, and the postdrome. The prodrome is the first stage of the migraine that begins hours to days before the headache that is distinguished by irritability, fatigue, and confusion. Then there is the aura, which happens an hour before the headache. And finally, the last stage is a postdrome, which lasts up to 24 hours and includes similar symptoms as a prodrome. But what exactly causes all these symptoms? Researchers are still trying to figure it out. 50 years ago, the main theory was that migraines was a vascular disease caused entirely by the activity of the cranial blood vessels. Today, in addition to the role of vasodilation of these blood vessels, there are multiple hypotheses at work. One such hypothesis is that migraines are caused by neurogenic inflammation, characterized by the release of neuropeptides including substance P, calcitonin gene-related peptide, CGRP, and vasoactive intestinal polypeptide, VIP. This is thought to cause nociceptive transmission, aka the pain signal, to the brainstem and upper spinal cord. In terms of the aura's experience, the cortical spreading depression that is seen in migraineurs might just be the cause. The origin of these neuronal mechanisms are not sufficiently known and need to be studied further. But let's back up. What do you do if you have migraines and want to make them stop? Drugs.
Actually, it's a bit more complicated than that. When treating migraines, you generally have two treatment options: acute or prophylactic. Acute treatment is what you want when you're having a migraine. They're the ones that make them stop. However, these aren't recommended for chronic migraines, unlike prophylactic drugs, who are taken before experiencing a migraine to prevent it from happening in the first place. While most drugs are uniquely acute or prophylactic and may only offer pain relief to one type of migraineur, some may be both acute and prophylactic in nature. In terms of acute treatment, there are many options available on the market. The clinically best and most effective example is triptans. The mechanism of action is through the selective binding of two specific serotonin receptors. Triptans are believed to decrease the release of vasoactive neuropeptides and directly decrease the nociceptive transmission within the brainstem and the upper spinal cord. Although these drugs are one of the most effective in reducing migraine attacks, they have multiple contraindications and side effects such as dizziness, neck pain, and in rare cases, strokes. They are also usually only available with a prescription or a previous diagnosis of migraine. Another acute and possibly prophylactic treatment for mild or moderate migraines is NSAIDs. NSAIDs are known to inhibit the COX-1 and/or COX-2 enzymes to prevent the formation of prostaglandins. This in turn inhibits both the inflammatory response and the peripheral activation of the trigeminal vascular system while increasing the pain modulation pathway. This is great since they are available over the counter and thus more accessible. But NSAIDs also come with some GI side effects, and there may even be some cardiovascular risk associated to them. For purely prophylactic treatment, antiepileptics like topiramate are thought to prevent migraines by reducing excitatory and increasing inhibitory nociception neurotransmission. That is, both in terms of the trigeminal vascular pathway and the cortical spreading depression associated with migraines and auras. The effects may take a few weeks to start, but they seem to last with continued treatment. Unfortunately, these come with side effects ranging from paresthesia with topiramate to tremors, alopecia, and even birth defects with valproic acid. Finally, one prophylactic treatment that is very promising is the use of Ona-botulinumtoxin A, or Botox. In short, Botox is injected in specific muscle injection sites where it will prevent the release of vasoactive peptides, interfere with ion channels in meningeal nociceptors, and directly affect central nervous nociceptive transmission. This treatment seems to be effective in reducing the number of migraines and increasing quality of life in chronic migraineurs, but it doesn't have similar effects for episodic migraineurs. Botox also comes with side effects like neck pain or muscle weakness and needs to be injected by a professional. But at least it doesn't have the risk of medication overuse headaches like all the previously mentioned treatments.
As we've seen, the symptoms of migraine are well classified, but the exact mechanisms behind these symptoms remain ill-defined. Unfortunately, this means that even though there exists a diversity of treatments, they are not effective for many people. A lot of research in this field is still needed to find suitable treatments for everyone.